Okay, so can everybody hear me? So welcome so much, and I'm really excited to have our first event in our new building, so welcome. And I'm also very excited that we have the opportunity to have a very special guest who's just come in recently from Vancouver, Canada, and who can give you such an exciting topic as technology planning for hospitals in the future. I think it's a really exciting topic, and I think you're going to really enjoy the talk. So let me first just introduce our speaker. This is Phi Kim Ho. He is actually at our Arcadius IBI group, and with over 20 years of industry experience, he provides leadership within the firm, holding two roles: technology systems architect and practice lead. And as practice lead, he is responsible for scaling the technology consulting practice globally. As a technology systems architect, he is focused on human experience-centric technology, strategic planning, and digital transformation. His practice is sector agnostic, which enables him and his team to gain significant penetration into sectors such as healthcare, higher education, justice, corrections, civic, and workplace. Some of his recent healthcare engagements include developing technology strategies, Vancouver Coast Health, Unity Point Health in Iowa, Children's Healthcare of Atlanta, Baylor Scott and White in Dallas, and the Cleveland Clinic in the Florida region. And most notably, and he'll talk about it today, is the $1.9 billion St. Paul's Hospital in Vancouver for Providence Healthcare. So really excited to have him. Please give him a well-deserved round of applause, and we'll turn it over to him.
Okay. Thank you. Can you hear me okay up there? Yeah, it's good. Just a privilege to be here. I've been coming to London a lot for vacation, but I haven't been here for work. And since joining Arcadius IBI about 3 years ago, I was expecting to do a lot of travel, but then this little thing called COVID hit, and so the travel kind of got put on the back burner. Now we're catching up. Now I'm talking to my wife that I'm traveling a bit too much because every couple of weeks on the road is a bit too much now. Do you guys know where Vancouver is on the map? It's a 9.5-hour flight, direct flight from London. It's actually pretty quick. It went by pretty nicely. So what I want to go through today is I do a lot of work in my consulting practice as a practice lead within Arcadius IBI. Arcadius IBI is about 35,000 people worldwide. We have offices in all the continents, multiple offices throughout the cities. There's about 5,000 of us here in the UK, and we are architects, engineers, solution developers, software developers mainly in the buildings industry. Where I practice is mainly in the buildings industry as well, and which brings us to hospitals. Back in the day, technology was always an afterthought within hospitals, where you would design the spaces and then an engineer come by and throw some IT in there, some Wi-Fi, and away you go. Now that's changing. Now one of the highest priorities is, do we consider technology when planning for hospitals and campuses and systems? I'll use the term systems very much like here NHS. It's a system. In the States, it's called the system. In Canada, it's called an authority. So the authority of the system, they have multiple hospitals within their portfolio, and they're looking at it as a system-wide solution. So we start to find out that technology does have an impact on planning. It has an impact on patient outcome. And it would be silly of us not to look at technology and see if we can leverage it at early stages of planning and not wait till the end where you've already got your functional program, you've already got your space allocation, schedule accommodations, and then you're saying, well, why do we need such a big waiting room? There's only 2 people there because we're remoting in now. So things like that starts to impact. Do we need AGVs to do our logistics in moving laundry and food throughout the hospital? Where is the break-even point? And when we do AGVs, do we have to plan it in at the beginning? Absolutely. If you bring in AGVs after the fact, you realize that the hallways or corridors are not wide enough to have AGVs and people walk through. Now you've precluded yourself from automatic guided vehicles to move logistics throughout the hospital. So things like that come into effect. Now we're talking about digital health. How does digital health impact the physical space as well? So what I want to do today was really go through some of the planning process that we do and how it kind of folds into the overall architectural planning as well. Then I'll give you some of the examples of some of the tech innovation opportunities. I'll try and wrap it up in about 30 minutes, and then we can open up for conversations after that as well. Okay? So going through that, really what do we do? We're integrating enabling technologies with an organization to facilitate human-centric transformation of its core business. Again, this is a school of healthcare business. We focus on the core business. We think that technology can enable and transform as tools, as an enabler of transformation. It can't transform it directly. It's an enabler of that transformation. And we always say human-centric. Human centricity is absolutely paramount for us. There's no point in rolling out technology if it doesn't improve the human experience, whether it's patients, staff, partners. It's all about the people that are using or encompassed within the facility and the technology itself. There's a couple of quotes from Steve Jobs I thought was kind of neat. You can't just ask customers what they want and then try and go and get it for them. By the time you get it to them, they don't want it anymore, right? They want something new. And when you're planning for technology, that's oftentimes the scenario that we're in. It's like, give me the latest and greatest. But when you're planning for a hospital, sometimes these large hospitals are getting bigger and bigger. It's not going to be into like 9 years from the time of planning to the time you move in. It could be 8, 9 years. So how do you plan for that technology? Instead, I prefer to go with the second quote again, Steve Jobs. Let's just go invent tomorrow rather than worrying about what happened yesterday. So we have to really look forward into what is tomorrow. And I can't depend on the clinical people to tell me what they want because they don't know what they don't know within the technology realm. They know their business, they know what they do, but we can't expect them to come and tell us, oh, we want this widget because it makes our life easier. They don't know what that widget is. So we have to develop some tools to figure this out. And how do we do that? So really, there's multiple ways. We can apply the same process, and I'll go through some of that processes in a minute, and it can yield very different results depending on one major factor, the technology culture of the organization that we're working with. And so some of the organizations that I'm pulling from when we're doing this is Vancouver Coastal, Province Healthcare, Fraser Health, Northern Health, Interior Health. We're all Canadian health authorities or health systems. NHS, you guys know. And then in the U.S., the ones I've worked with is Children's Healthcare Atlanta, Baylor Scott White, Cleveland Clinic, and Unity Point, throughout, right from Iowa all the way down to Texas. And there's a very difference, and all the way from UCSD down in California to the Cleveland Clinics in Florida. So really coast to coast, north to south. Some of the methodologies that we look at. One of the things is we need to go through a discovery stage. It's a bit of an eye chart up there. I think you see it. Good. So this is important. This is where we're starting to look at what are the technology visioning, what are the business drivers that we're going through to develop this technology. We start from the business drivers, we start from the business of healthcare. From there, we go into research. We do a market scan. We look at what other hospitals in that region are offering with the same types of programming of the services that they're providing. We also do a scan outside of healthcare because it's important that if we're looking at some innovation, we need to make sure that the technology is proven. And if we can't find that proof within the healthcare sector, we need to be able to provide that proof from outside the healthcare sector. Sometimes things have been, code white, for example. Just an example, when you press a button, you have to know where that staff member is when a wireless code white, because they're depending on their staff members to come and help them should a situation escalate with their patients, especially mental health. That was rather novel to be able to use a wireless device to locate a staff member anywhere in the hospital. But the correctional facility has been doing that for 10 years already, where a staff member, corrections officer, when an inmate is attacked and they hit their panic button, wireless panic button, they know positively where that staff member is so they can respond to that staff member. So we just borrowed that technology and that proof from the correctional facility and applied it to the hospital. So it is not proven in the hospitals, but it's proven in another sector, which is important to the market scan outside the healthcare by itself. That's when I get into ideation. And this is where we start coming up with ideas. And I'll show you some examples on the ideas that we have with some of our projects. And this is the fun part. This is where you start coming up with opportunities to innovate, opportunities to improve certain processes based on our observations that we had from interviews with clinicians and user groups and such. At that point, within the process, we have to align our ideas with the overall vision. The hospital system, the healthcare system, has guiding principles. They have pillars. We can't just have a technology strategy on its own on a remote island. It has to align. So we have to show that there's alignment with the overall strategy. So we go through alignment phase. Then we document everything. Of course, we have to get all our ideas in our head down on paper so that people can actually see it. From that point, the outcomes of that are basically a technology vision statement. We have innovation opportunities, and then we have this harmonized physical-digital experience. And I'll show you in a second why that's important. It's not just the physical experience as well. We get frustrated in the physical world, but if you ever use an app that doesn't work the way it's supposed to work, or a software, you get frustrated in the virtual world as well. So it's important to see and harmonize that patient experience, because sometimes you traverse between the physical world into the digital and back to the physical, and the experience you get should be consistent throughout. It should be pleasant. You shouldn't feel frustration, whether in the physical world or the digital world. So when you're planning, you need to be planning both realms concurrently. So how do we predict what's going to happen in the future? I'm sure you guys have seen this hype curve before. Whenever new technology comes out, it goes through a hype, visibility, excitement over time. Something happens, an announcement. Apple says iPhone 21 is coming out, and then you go through this hype curve that goes up really high, up to a peak of inflated expectations. At that point, no product can actually meet your expectations. You can think this thing will just do everything in the world. It doesn't. So then that product or that technology goes into a free fall, into the trough of disillusionment. This is interesting because this is where products, smart companies, they pivot. Amazon stops selling books, start selling other things. So they pivot, and then they come out of that. The ones that don't pivot, that don't react, they die. That technology dies in that trough. The ones that actually successfully comes out of it, they come up this slope of enlightenment where they start to show this utility behind it, and it is innovative. And eventually, over time, you hit that plateau of productivity. By that time, it's table stakes. If you're trying to compete at that level, you're already behind. So we look at this, and new technology gets plotted on this graph every year, actually quarterly, and we track things. We track things like the Metaverse. Where is that? Where is that in the slope? Right now, the Metaverse is back on that slope of this peak, before the peak. Experts think it's 10 years away. I think it's probably 15 years away. The digital customer, the digital patient, is also it's a digital twin of the patient, which is really unique with that side. You can imagine having a digital twin of a patient within the Metaverse, where you're taking real-life data, population data, feeding it in, but also all the data about that patient itself, and be able to simulate different outcomes or predict different outcomes to give you some input on what treatment that the patient perhaps could go through. So it's something pretty interesting, some novel ideas on that side of things. There's another thing that we look at, the Kano model, and I'm pretty sure you guys have seen this before as well. On a graph where there's like the feature, whatever technology comes out, whatever feature comes out, we have we look at the customer satisfaction or delight. The first curve, as more features get enhanced, it's a nonlinear curve of delight. That straight curve, that one I think is table stakes, where you improve the performance, everyone's happy with it, but it doesn't really give me delight. Yes, the computer's faster, but I don't get excited that the computer's faster. And then eventually what happens over time, that delight curve pushes down into the must-have curves or table stakes. Here's an example. Back in the day when Wi-Fi first came out, it was free in hotels. You were delighted. You come into a public facility, into a hotel, and it's free Wi-Fi. Wow, I'm happy, I'm giddy. And now if I go into a hotel, they don't give me free Wi-Fi. I'm angry that they don't give me free Wi-Fi. So that's what I mean by things go through that. We stream our content all the time, and we can stream movies. We We can view whatever we want, and we can view them in high definition. If it comes into low definition, we kind of get angry because we expect high definition. But back in the day when we streamed them, we thought it was just awesome just to stream content, stream a movie. So what does that mean? So a lot of times we do technology strategies for patient-centric, digital-first hospitals. We hear that quite often in hospitals. We take that same goal, the outcomes are really different. This is a case study for a hospital in Texas. Texas is, for hospitals and innovation, it's hyper-competitive for talent, for people to come by, staff, hyper-competitive for patients, customers, and they try to leapfrog each other. They try to one-up each other in Texas. Interesting place to work, interesting place there. So this particular project, the client wants to be a fast follower, but really they say they want to be fast follower, but within the Texas market, they're actually a market leader. Within the hype curve, they're positioned up at around the peak, for example. That's where they want to be. They're okay with that. They're okay with testing technology that may not make it over the next 5 years, but they don't have a choice. That's how they have to be within the competitive nature. Whereas you go to the hospital in Vancouver, they are digital first as well, but they've positioned themselves around that drop into the trough of disillusionment. So they're starting to see which products do that pivot and then buy into that when they do that pivot, and then they can catch and ride that curve and ride up the slope of enlightenment. Much more conservative compared to the previous example. We go to Iowa, different story. Iowa also wants to be a fast follower, but really for them, they're almost a laggard. If you position yourself in the productivity plateau, you're a laggard within the technology adoption. In this particular case, we're pushing a little bit. We're getting to be a fast follower. And for them, they're in that top end of that slope of enlightenment because they're just much more conservative with the technology. So same goal for all three regions, from Vancouver to Iowa down to Texas, very different positioning on how they can adopt technology. And this is important because when rolling out technology, if the gap between the technology culture and what we're trying to do is too big, you're going to have failed deployment. So you have to find out, you can move up and down a little bit, but it's really tough if you had a hospital in Iowa, which is much more conservative in the technology use and digital transformation, trying to align themselves, compete with a hospital in Texas, which is much more cutting edge, then there's going to be a failure. They're going to use 10, 20% of the actual technology capabilities that is present. Same objective, three different outcomes. Alignment. So this is again in Iowa. We took all the technology initiatives and then we create themes out of them. We had a theme of joy, flow, and fabric. Joy is things that elevate the human experience, whether it's for patient or family or staff. We have flow, which is really about workflow, whether it's going to be workflow within the operations of the hospital or flow of the care continuum itself. And then we have fabric. That's the stuff that happens behind the walls that nobody cares about unless it's broken. Then you care about it. That's the stuff that no one sees, but it has to work well. And the green items on the side are the guiding principles of the healthcare system. Everything we do, we have to follow those guiding principles because it supports the overall healthcare system's vision. And so we show that there's alignment between the technology themes and the guiding principles of that particular healthcare system. So how do we do that? This is a real plot for one of the hospitals we're working on. We create a matrix, and this is a snapshot of one of the matrices. It's in progress. And we plot out the different moments of influence because we know that your care continuum for a patient going through a hospital, through the different departments, there's moments where it can inflict joy or it can inflict pain, I guess, and frustration. And so we look at those opportunities of moments of influence, and then we come up with ideas on how we can elevate the experience in that particular moment itself. And the moments themselves are strung together eventually into a journey map. So we zoom in a little bit. We have this offstage. There's a bunch of technology that happens behind the scenes that nobody sees, but is there. Command centers. Pretty much all major hospitals have command centers. 10 years ago, command centers were stuff you see in military facilities. Now it's something that you'd see in a hospital. It manages not only the operations of the hospital in the physical world, but telehealth, virtual health, everything that deals with that side is also managed from the command center itself. Across the top, you see that there's a pre-arrival. So what happens during pre-arrival? We're starting to see applications come out, apps, that we can book our appointment ourselves. We can do self-check-in. We can do a lot of things from the app that's coming out. And it's not just an app that is kind of marketing, communications type of thing, but it's really getting to a point where you can actually see your medical records and things like that through the app. Much more user intensive. One of the things that and I'll go through this, I have feature sheets for one of these, so I'll go into more detail later. There's also the moment that's pre-arrival as you're coming to the hospital, and then there's arrival when you actually land at the hospital. So when planning for a hospital or a campus, now we're having to think what happens before people even come to the hospital that we're designing, right? Which is something that is before perhaps you're not thinking about that. We only care when they get to the hospital. Now we care when they're at home before they come to the hospital, which means that the patient journey is now really becoming 360, right? You start at home, you come to the hospital, you get your treatment and stuff, and then you come back home again. So it's a much wider scope than we used to plan for. You get into the lobby. What happens at the lobby, at the admittance area? What happens in, for example, this case is arrival into the emergency department, and so on and so forth. And you'll see the pause moments. We're going to have to wait, but it depends what you do during that wait. We know that the time is constant, in most cases. Time is constant, but our perception of time can change. And how we design the space and what we do in that space, we can influence people's perception of time. So when things like a wait is actually not that great to wait, we can do things that the wait feels shorter. And we've looked into studies that it will show that. When there's time where you need to slow down because people have to process more information, we slow down time or perception of time so that they can do that. And overall, by playing with that perception of time, we can improve the human experience as they're going through that continuum itself. Disney is really good at embracing the wait. I can wait in line for an hour for a 5-minute ride, and I can still feel like I'll go again afterwards. So they're really good at changing your perception of time when waiting for rides. And now we take those things, and we put it into a journey map. And this particular journey map is an exemplary of the bottom half is the digital journey, and the top half is the physical journey. But the journey itself weaves itself between physical and digital. So, for example, pre-arrival, I may take this, I may schedule my appointment, I can connect to my doctor, I can talk to the doctor, I can text to the doctor, and then I can plan my trip. So that's pre-arrival. When I arrive at campus, now we're starting to borrow smart camping or smart parking from parking garages that we see at airports, like you do here in London. If you forget where you park your car, you can just enter your license plate number. It tells you where you last parked your car. Proven elsewhere, not really used in hospitals. So we take that and we apply it to hospital because you're coming into the hospital, you may be stressed. The smart parking garage can actually talk to your car. It can suggest, hey, I know you're going to building B. The nearest parking is in parking garage A. Do you want to navigate there? You hit yes, it updates your GPS, it guides you to that parking garage. Once you get into the garage, instead of driving around looking for stalls, there's guidance lights on the overhead that gives you green indicator when the parking is available, red indicator when it's not, so you don't have to drive around looking for it. All this stuff is already available everywhere in other sectors. We're just bringing it into the hospital itself. And you park your car and you leave, and a lot of times you forget where you park because you're stressed. You're coming to a hospital. It's not a fun thing to do at times. When you get to the lobby, great, we roll out all this technology for the patient itself. We're borrowing ideas like the Genius Bar. We need to support the staff. We need to support the patients. The patient wants to come and learn, hey, I heard that I can book online. I know I can connect with my doctor online. Can you show me how to do that? You can book an appointment to come in, similar to Apple does with the Genius Bar, and get a tutorial on how to use the technology that the hospital systems are pushing out to the patients. We always forget. When you push technology out, there's people on the other end that has to use it, right? It's pretty simple. And now we're planning into the lobby area a tech lounge. And the tech lounge a lot of times has 3 zones. And the first zone, sometimes I feel apprehensive when I go into a tech lounge. I'm kind of shy, I'm kind of embarrassed, I don't know how to use my technology. So the first part, very hands-off, it's more exploratory. Then you kind of go into the next stage where there's more presence of advisors to help you. And then the third stage is you walk right up to the bar. So depending on your confidence level and your comfort level, you can choose where to go. It's not clearly delineated within space as stage 1, 2, 3 in the space. It's just cues from the design of the interior space to get to that comfort level enough to be able to get help. Down below, we have virtual concierge, and this is legit in the sense that because of the staffing problems, we oftentimes in a unit, we have our care team station, but then you have a unit clerk. And we found out the unit clerk, most times, is just directing traffic. People come by, they don't know where to go, they're directing traffic. And so in this particular hospital, we're putting in this virtual kiosks where you can talk to it or type on it. It's a touch interactive screen. And you can ask where to go, and it gives you navigation. And at some point, it asks the question, do you want to push to your phone? You hit yes, then a QR code shows up on the screen. You point your phone at it, and it beams the directions to your phone. And then from there, you use augmented wayfinding to find, in this particular case, Dr. Williams' office, for example. Why that's neat is because now they don't have to have a staff member sitting at the unit clerk. They can have the clinicians actually focusing on patient care as opposed to directing traffic. At any given time on this kiosk, you can say, oh, I wish I could talk to a real person. It listens to keywords, and it'll click you in and ask you, would you like to speak to a real person? And then it opens up a video conferencing to a person that actually helps you through the direction. So there's always a live person there if you need to say it. You don't have to ask for it. It's just listening for keywords. Sort of like how Alexa listens for Alexa at home, right? Sometimes it just comes on. Once you get through that, you get to the check-in. This is, again, this is the same journey mapping. At check-in, you're looking at, just like at a airport, either right now we're not using NFCs yet. Eventually we can use NFC or near-field communications that it can actually just detect your phone that you're there. But we found a lot of times people may come early to the hospital, maybe go and hang out in the nice coffee bar that we keep seeing in the lobbies themselves. When they're ready to check in, they'll walk up to the machine and then scan the barcode to let the hospital know that they've checked into the hospital itself. From there, you can go up and we embrace the wait. And again, this is an idea where we have these concierge robots. And this concierge robot, you can order through your app that you want some fresh foods, drinks, whatever it is, and this robot brings it to you in the waiting area so that you can have this. Vending machines have a hard time keeping fresh foods fresh, and so having the robots that actually bring fresh foods as opposed to unhealthy food that's in the vending machines. So that's another idea where we can try and speed up that perception of time because you can do something within the waiting areas themselves. And then from there you go into the actual procedures. So this is an example I was talking about with the parking, where this is an exact sheet that we used with the healthcare system we worked on, and we show them the smart parking garage and the technology. We actually go through an assessment of it's a qualitative assessment as opposed to a quantitative assessment. So we're going through and we say, okay, the value, we think that the parking guidance is of high value, and that's what we suggest. That's a value impact assessment. And we say that the confidence is high confidence because we know this technology, although not widely used in hospitals, is widely used in airports and shopping malls. The cost impact is medium, and then we look at an organizational impact. Does it just affect the service line, which is the department itself? Does it affect the tower, which is the new tower on a healthcare campus? Or does it affect the whole hospital, which is the whole campus? Or does it affect the entire system, meaning multiple campuses together? So in this particular case, it would affect the whole hospital campus, not just the building itself. And then we look at experience map or experience impact. Having this would, I think, and our opinion was, it would elevate the public, the patient, the visitor, and the staff experience. Whereas we go into this next one, which is of high importance, but this is the integration of healthcare technology for auto data entry. So as we go more and more towards digital hospitals, there's more data. And the more data, we have to think to ourselves, who's entering this data? Could you imagine paying a clinician to sit there and just data enter? They're not going to have really good job satisfaction and end up losing staff. So we start to look at what's called RTLS, real-time locating services, and we start feeding in data based on location and time where patients are or workflow is within the actual flow itself, and automatically enter data into the electronic medical records, the EMR. So for example, a patient may be going from pre-op to op to post-op, it automatically updates and starts pulling inventory through for cleaning of the rooms and notifying patients, or notifying family, I should say, where they are within the care continuum. A lot of times you go into the waiting area, you have the OR waiting room, waiting area, and it shows a code for the patient. Your family member may be in there. It tells you where you are. This will automatically update that for you as well. So this is critical because the more and more we go towards data, the amount of data that we're going to be consuming, the amount of data that we're going to be generating is exponential. If you expect humans to go and enter that data, it's going to bog down the whole system. So using real-time automatic data entry is key to digital transformation. This is the app. We talked about the app as well, just elevating the functionality of the app itself. This was neat. We found out that there was a big problem of marginalized patients not getting, a marginalized population not getting to the hospital itself because either they don't have a car, they can't get access to a car, and they just become a no-show. No-shows are expensive. No-shows, you have to prep the space, you reserve the space, you have the staff in place, and all of a sudden the patient doesn't show. So it's very inefficient. So this is a program where it connects the EMR to confirm that the patient actually has an appointment with Medicaid, who pays for it, with a rideshare company to come pick you up and take you there. And it's all automatic. And this is something that's done by U.S. Department of Transportation, so U.S. DOT, that we're in a pilot with to be able to offer this up at no cost to the hospital systems. So this was a no-brainer for that particular hospital. Harmonized physical digital journey, we talked about that. And that virtual concierge is this, here's some pictures of what you might see it as. Augmented wayfinding, where you actually hold your phone up. It's using the phone's cameras and superimposing arrows to kind of guide you through that. Again, been used in other facilities, not so much in hospitals. This was a neat one here, and this really came out of COVID, where the patients are in the hospital and their family can't visit the patient, or the patient has a regular, the nurses or clinicians are doing the regular rounds throughout the hospital, but there's certain patients that require more than the regular rounds. And so they're using this system, the virtual health, to be able to remote into the room to increase the number of rounds going through. But what was really important is that a lot of times the patients in the hospital, the caregiver isn't allowed to come to the hospital, so we can use this system, or the caregiver may be living in a different city. The use case is that there's a lower picture here that we have a patient who's a senior, and the caregiver may be living in a completely different city altogether. And this was in Iowa. And he couldn't be there, so now he can remote in and actually be a part of that consultation that's happening between the physician and the patient itself. This was a high value, just because in the U.S. things are, the cities are quite spread apart. Patient bedside devices, allowing not just to be able to call for nurses, but to be able to customize the room. We see that already, change the temperature, change the lighting, but also be able to do patient entertainment through that and patient education through that device as well. Order food, provide preferences, ask for water, things like that. We find that a lot of patients, they feel that the clinicians are doing really important stuff. I'm thirsty, but I don't want to interrupt her because she's really busy, so I'll sit here and be thirsty and not be happy. So using technology to be able to do that allows that to be automated, so you don't feel bad for asking for water, and the patient's happier as well. Using that same real-time locating services that we talked about earlier, and the next idea is to take those tags and tag the equipment. So the use case behind this is that the patient is in the room, they need an IV pump, or not need an IV pump, but the IV pump is in the room. So do you know whether that IV pump is located? Yes, because I've tagged it, I know where it is. But do you know whether it's being used or not? We don't know that. So what is the utilization of the equipment? How do you plan for equipment when you don't know the utilization? So in this case, We take the patient in the room, the patient has a tag, we know the patient's in the room with the IV pump, and it asks the clinician or the physician, do you want to associate the two? So there's a button you can press to associate that IV pump with the patient. So now in your EMR system, you can see that that IV pump is actually being used. If it doesn't work, in the past, what happens is you take that and you wheel it into a room and you say, I'll log it later, and then now you have a room that's full of half unused equipment. In this case, if you double tap on that button, it automatically logs to the biomedical department to say that this IV pump is no longer functioning, it needs repair, and it sends a location to the biomed group so they know exactly where the IV pump is and it's not working. They can go retrieve it and fix it. So things like that streamline the operations, but also helps the patient and the staff. AGVs. Normally when we did for that St. Paul's Hospital, that $2 billion hospital, we had to do a case study back in 2017. When is the payback period? What's the ROI on using AGVs? It costs money. It replaces porters, so it moves food and laundry up and down, and it goes on its own, but you have to make the hospital corridors wider, And so we had a 5-year payback period that we had to meet. And when we did the analysis, the hospital had to be around 450 beds. That's about a 1 million square foot hospital. And so about 450 beds is the payback period of 5 years ROI. We go to this other hospital, they only have 150 beds. And we're saying, well, you're going to have like a 15-year payback period, which is not a good ROI. And so, but we dug a little further and we asked and we found out that the average age of a porter for that particular hospital system is 62 years old. Some of these carts are about 250 pounds. So you can imagine a 62-year-old porter, male or female, I don't care. Even I have problems pushing. So you're pushing this cart 250 pounds and somebody's in front of you. You got to slow that cart down before you run over that patient there. And in 3 years they retire, you're not going to have a workforce to push these, and they can't recruit, they can't pay enough. There's no porters around. So staffing shortages has now become a problem that blew my previous case study out the window. Now we have to ask ourselves, if we don't do AGVs for logistics, what's going to happen? Well, in 3 years, we're not going to have anybody because they'll be 65 and most of them will retire. So we're going to have to shut down beds. So we can't take in enough patients and reduce the overall capacity of our hospital. So now the payback period is like, well, we can't afford not to do it, so we have to do it for 150 beds. So that's kind of an example there, that type of analysis they have to go through. Now, luckily, this is during a master planning process. So then we take that information, we feed it back to the architects who are doing the master planning. Now we're sizing the corridors wider. It's going to be back of house mixed with staff and robots, but we'll put a line down the middle, so like a robot lane. The reason why that's important, because these robots, when they move the carts, they have detectors, so they detect somebody in front of them, they stop. But when the corridor is narrow and you don't allocate space for the robots, they keep on detecting people, so they just travel 2 feet and they stop, 2 feet and stop, and next thing you know, you have a bunch of robots and it's a traffic jam in the corridor and nobody goes anywhere. So that's why you have to have special lanes for them. Now, I'm just going to wrap up here and give some time for good discussion here. This is the hospital in Texas. They really pushed our thinking of digital health to the point where we had to look out 10, 15 years and then pull it back to do something that we can align them so that they're not precluded from it. And it's talking about the metaverse. The metaverse doesn't exist right now. The metaverse is like a persistent virtual world. It's a 3D internet, how you consume data through internet. And it has to have commerce to it. And so there's games such as Fortnite and Roblox and things like that, or Minecraft, that are examples of what a metaverse could look like. What's important about that is if you had a healthcare metaverse, it's this virtual 3D persistent world. It has to be persistent. It's on all the time. You can't just, it doesn't just come on when somebody's in it. It's continual to run whether you're in it or not. And so if you think about, you imagine what a 3D universe would look like, and you have a virtual version of the hospital in there. You have digital patients in that metaverse. You have service providers offering services through that metaverse in a way that that is consumed in a 3D through goggles or a 3D manner. You can transport from one metaverse to the other to promote different programs that are happening. So it becomes this 3D virtual commerce that is helping not only, it's not just fun, that's not just the point, but the point is that now we can look at it, we can start to simulate things. So if I had a hospital and I have a digital twin of the hospital within the metaverse, and I'm thinking that I want to improve a certain workflow because I'm tracking staff and patients and I know which route they're taking, what if I made these changes within the hospital for process improvement? Because otherwise you would typically build a hospital, brick and mortar, and you don't touch it again for, what, 30 years? And so how do you know if that flow that you envisioned at the beginning is going to work? So this way you can take real data of how people are using the hospital, and through AI analytics, you can predict if I move this direction this way, would staff actually go that way? And so you can start seeing, can you improve the flows throughout the hospital by changing the configuration of the hospital itself based on real data? And it'll continue to feed real data into it as well. So that's really pushing it. That's really pushing the thinking really far into leveraging the metaverse for healthcare practices and planning. Now you got to plan things in 3D as well as in real life. So I'll stop there because I do want to leave some time there for some conversation, if that's okay. And hopefully I've given you guys some things to think about when you're planning, and or at least not scare you guys from seeing the future.
All right. Well, I thought that was fascinating, and yeah, I find the metaverse very confusing. I'm trying to understand what value the metaverse would have. So can I ask you that first? How would we use the metaverse in healthcare? Is it just to simulate and learn lessons from it, or how would we actually have real patients engaging in it?
So really, the concept of a metaverse is to facilitate the constant communication between the healthcare system and the healthcare users. And so if you had patients using it, but also your healthcare partners. Now, the partners may be doing diagnostics off campus, and they're able to do the diagnostics, and we're looking at eventually into 3D scans, and to be able to present that and have that the health metaverse as a hub. So it'd be like a virtual world, similar to what you think of a local area network that we have today. And then a bunch of virtual worlds connected together makes the metaverse. The metaverse is the stuff in between. Sort of like today, the internet connects different hospitals together and different partners together. So it allows the patients to be able to oftentimes go to a digital twin of the hospital and walk through it first just to get some familiarity of it before they actually come to the hospital. But really the power behind it is doing the simulations. And we're talking about if we had a digital twin of a patient within the digital twin of the building and be able to do simulations on their flow, we can look at that information to improve the experience of the patients coming through the hospital itself.
Great. Okay, so we're going to open it up for questions. If you've got a question, I can just come to you with the mic. Does anyone have any questions? All right, let's start back here and work our way down.
Okay, thank you for your excellent presentation. And I'm wondering how can the elderly who are not really good with technology deal with this kind of digital transformation, and would they going to be left behind?
Sorry, who?
The elderly who are not good at technology. Yeah.
That's a great question. So with the elderly that may not be fast adopters of technology. So there's although we lead digital first, there's always a human presence behind it. And so we would never have, well, I guess I shouldn't say it. Most service lines, nearly all of them, always have the ability to fail over to talking to a live person to help you out. And we understand that. To the point where sometimes if you don't have the technology at home, because it's something we're dealing with right now is a digital inequity, or this digital inequality And it doesn't have to be elderly to the younger demographic that may be technology adept. It could be people that don't have technology at home. What if you don't have the bandwidth, you don't have a high internet connection at home? How do we do the virtual health? So now they're not getting access to healthcare. So we're even considering building prefab pods that would get pushed out to community centers, libraries, things like that, so that patients can actually go to, instead of traveling to a hospital, they can go to near like a community center, and there'll be staff there to help them to learn about the technology as well if they don't have the technology. But also that tech lounge is another place where we are supporting people so that they can actually go there and get some help how to use that technology. And if they still don't want to use it, you can go up to the counter and check in the old-fashioned way as well.
Adding all those digital services, will it have an impact on the price that the patient pays for like the delivery care? Or is it the hospitals that have to deal with that? Or where's the money coming from?
That's a great question. So the financial aspects of this planning, it depends on which region you're working in. In Canada, healthcare is public. It's free. If we don't really know how much things cost in Canada, I'm not even being facetious. That you really don't know. We know the overall price tag, but how much does this process cost? We don't really know. Whereas the U.S. market is privatized, and so you know what things cost. And so we always have to look at what is the cost, and does it reduce the cost of delivery of services, or does it increase the patient experience, which attracts more patients, which attracts more revenue. For the cost side, you can look further into, like, for example, you have, biomedical or wearables, right? So you can take IV meds at home with an IV machine at home that can be connected through 5G cellular back to the hospital, and that command center is monitoring it. There's studies showing that could reduce the cost of that particular procedure by 30%. And so it's actually cheaper to do it at home through enabling technology than it is to have the patient come into the hospital. And we all know that people heal better at home than a hospital, so we want to get them back home into the comfort of their homes more. So it depends on which region you talk to. You can actually have a business case behind it.
Yeah, thank you for an amazing presentation. I just wanted to know, what do you think are the most important use cases for the metaverse in healthcare? And also, just a side thought, I was thinking some of the use cases that I've seen the metaverse being used in healthcare is quite complementary. And do you think is economically sort of viable for a company, for a hospital to sort of invest in the metaverse, being that some of the use cases are quite complementary?
My opinion, no, to the last question, that is it worth it for a hospital to invest into the metaverse, in the sense that it's so far down the line, we don't know what it is, we don't know exactly what the metaverse is, and the challenges behind it is these companies are trying to own the metaverse. They're going to create their own version of the metaverse and trying to own it. Hopefully it becomes the metaverse, just the same way how internet was at the beginning. But nobody owns the internet, right? It's the stuff that connects all these local area networks together. Nobody owns it. And so any company tries to own it, invest in it, and just develop their own metaverse, I don't think it's worth it. The use case behind the metaverse really is creating this ecosystem that people can visualize in different ways of 3D. An example in here is, the image is kind of foggy. Down in the bottom right-hand corner, you'll see the physician with the goggles on. And so they're using virtual reality to be able to view the patient's stats and diagnostics information, the imagery and such, and then they can step through a complex procedure through a simulation by practicing it before going into the real life and actually performing the procedure on the real patient. But the idea is that the surgeon would wear the same augmented reality goggles, and you're still seeing all of the diagnostics imagery that you have during the practice or the simulation version. So everything's familiar to you. The only difference is that you're now with the real patient. So that's a way that you can consume some of that information in an augmented reality version. And using AR is one way to interact with the metaverse. Another way is, this is an example where if you had a consultation and you have a case you're working on, but the physician may be in Australia, the patient may be in the UK, and you have a specialist that's in Texas, for example. You're able to meet within this virtual space. The patient is in the physical space. The physician, the surgeon, and the specialist are appearing remotely as an avatar, so they kind of float around as an avatar, and they're able to meet and discuss in a physical digital space that the metaverse can power. So it's not just meeting in Zoom anymore, right? You can actually go up and work with physical space or physical objects, and that gets represented into the virtual world as well. So that's allows you to mix the 3D aspect of the virtual with the 3D aspects of physical. So that answer, I think you had 3 parts. Did I get 2 parts? Okay, did I answer that then? Did I got both parts? Yeah. Okay.
Other questions?
Hi, thank you. So I'm a doctor in the NHS, and this sounds amazing, and I think it's got loads of potential. But with the issues with even estates here, I'm just wondering whether, or based on your experience with the NHS, what are the key sort of challenges you found with implementation, and also perhaps the key opportunities you think the NHS has for some of this digital uptake and implementation?
Yeah. One thing I observed here is that inconsistency within the NHS. You still have some hospitals that don't even have EMR yet, whereas you kind of have to have those baselines throughout because it's such a big system. I think that in the U.S. there's that competition for patients, and so there's that more the appetite to kind of push the boundaries. Canada is more similar to the UK in the sense that our healthcare authorities are similar to the NHS, and you have to really show there's a return on investment, and that's why we have to go through that process of showing if you can't pay for something within 5 years, it's just kind of off the table, right? And so when we have to do the AGVs, we have to show that the return on investment was 5 years. And you had 450 beds. That hospital is actually 500 beds, but it just made the cut to show that. So it is challenging to do that. I can't see a hospital. Like the metaverse is, again, this is really, really pushing it out there. But the challenges with the NHS, I think, is the same that we have in Canada, where it's public dollars, and it's tough to roll out that type of investment, especially when there's politics involved with it as well.
Thank you very much for your talk. I would like to ask you just the same question that Nora asked you, but not about the metaverse, but about blockchain technology.
From which, sorry?
Blockchain technology. Have you worked with blockchain technology, or have you, or do you think it kind of add any value, or do you think of any applicability into the healthcare sector? Thank you.
I think blockchain has a tremendous amount of value, and a lot of times you assume blockchain with cryptocurrency. Cryptocurrency could use blockchain, but it doesn't mean it's the same thing, right? But the whole idea of the zero trust behind blockchain and having all the transactions being carried throughout, and it's like basically you have an accounting log with every single block that gets added onto it. So I think there's tons of opportunity there to be able to address some of the challenges that we have with sending sensitive information around, and having blockchain and leveraging that blockchain to help with the sensitive information, I think would be really good. And it would help that interoperability, because the large challenge we find is interoperability between healthcare systems as patients travel for example, in Vancouver, we have Metro Vancouver. There's three healthcare authorities within just one city. And you don't know, you cross over from Vancouver proper into Burnaby proper. It looks the same, but you've crossed over into a different healthcare authority altogether. And they don't play together that nicely. And the interactions, and I shouldn't care whether I'm one side of the road to the other, but I think that blockchain has a tremendous opportunity potential to solve some of that challenge that we have with interoperability between systems.
Thank you for your talk. You mentioned about the home-based care, so we'll talk a lot about telemedicine. You mentioned about IV administration from far away, even the surgeries, virtual presence in surgeries. Then we are moving towards decentralization of healthcare, and that's going to be maybe the future of healthcare. Do you feel that, to have such a big investment, $2 billion for a hospital, is it going to be continuing in the future, or like we are moving more towards, home-based care? And
so why spend $2 billion on a hospital when we're going to decentralize it back to the home anyways?
Yeah,
really, right?
Advisable, do you look at the future also for the same kind of strategy?
Yeah, that's a great question. Where I guess I can sum it up in the sense that what I'm hearing and observing in these projects is that the types of cases that come to hospitals will be more serious and more acute, because the ones that aren't as acute are being dealt with at home. So I think the demand will still be there, because when we do master planning, we're projecting out 10 years on capacity, and if we think out 10 years we need 450 beds, then we plan for 450 beds, even if we move in with 300 beds today and we build a shell with empty spaces and then fit it out later as the demand increases. But I think the demand will still be there to come to that hospital, but there'll just be a different profile of illnesses coming in. And that St. Paul's Hospital in Vancouver, we planned that hospital to be like an airport. When you show up, the departments are very standardized and they all look the same, because the key priority for that one was agility. Today, we may be having this certain sickness, so we need this department, but maybe in 10 years, that illness doubled, then we can reallocate a second department, or we can move departments around. So as long as I come into an airport where you go to gate B34, today I'm flying to London, tomorrow I may be going to Manchester, or whatever city it is. So it's very generic and gets reassigned, and that agility to reassign. That's really novel, to be able to design departments to be a blank canvas that can be reallocated based on the demand of the population health. Right? So I think it's still going to be needed, because I think the guys who are planning it, they're pretty smart and using the data to see how many beds are going to be needed.
There's going to be more scope for the diagnostics to be, you mentioned about waiting time and everything. Diagnostics can play a very important role. Even we had the hypothetical case where the relatives can get themselves checked and everything during the waiting time, and everything. That can be a part of the system.
Yeah, cool.
So it just goes back to the metaverse and the use of virtual reality. I mean, currently there's quite a lot of use of virtual reality, especially in surgical procedures. What do you think the consequences are of a lot of tech being moved into, surgical management and managing chronic diseases as opposed to utilization in prevention? Do you feel that there would be a significant financial consequence on a lot of these global economies where we're not actually utilizing it as much for prevention of common diseases?
Yeah, that's a great question. I don't see the connection between using virtual reality with prevention. I kind of see them as helping each other out. It's just a tool. It's just an enabler. Why can't we use virtual reality and simulations instead of dealing with an illness that's already at the hospital? Can we simulate? What if we did this, public health, and had an emphasis on prevention? Does that change how many patients actually come through into the healthcare system? So I kind of see a complementary that why can't we use this technology, the VR and visualization, and focus on prevention as opposed to treatment. And I'm a big fan of that. Prevention to me is going to reduce the cost to the healthcare system. So I don't see the connection as one or the other. I'm not sure if I answered your question there, but it's.
Yeah, so I think the main question is the focus is on management, but it's not on prevention. So why do you think there is that lack in actually using it for prevention as opposed to utilising it for intervention?
Yeah. Yeah, I'm not sure. I'm not sure if the focus is on that. It's, whenever I'm working with the healthcare system, and especially in Canada, I go back to Canada just because it's most similar to the UK, and there's a big focus on prevention, and we know that it costs more to treat an illness than it is to prevent it, and this goes right into mental health as well, which is something that's coming up quite a bit within our population.
Yeah, you mentioned a couple new projects of new facilities. In terms of kind of existing hospitals we've got here in the UK, what other projects have you worked on where you've kind of gone in and completely retrofitted all the smart tech and implemented some of the strategies you've spoken about?
So new versus existing, brownfield versus greenfield. I have to say most of the projects that I'm working on are replacements. They're redevelopments. They're not just going in and retrofitting an existing site and not doing any renovations themselves. Usually when we go into master planning, it's because they realize that what they have needs to be replaced, or the facilities they have no longer meets the demand of the population. So we have to come in there and perform a master plan. And the technology master plan fits in with that. So they've always been either we go in and we basically demolish part of the building, build a new building, integrate it with existing. But it's never just going in and staying with an existing facility and just putting technology into it.
So can the technology upgrade be a driver for completely replacing the facility, or would it be the new facility and then you'll port in as part of the technological upgrade?
So can technology be the driver to replace the facility? Usually the driver to replace the facility is can the facility can sufficiently address the demands of the population health. And so other boring engineering stuff comes into play where, seismic upgrades, it costs more to repair versus replace, so there's that feasibility study has to go through it. But technology typically wouldn't drive the replacement of the facility. Usually it's whether the facility can address the cases that are coming in or not.
So I get the last question. So I would like to ask you about one of the biggest criticisms of technology is the cost. And of course, there's lots of studies that show that technology is driving up costs. And then that makes it really difficult to get governments and other organizations to really invest in technology. And part of the problem is, from my standpoint, is that we have a lot of technology. It's improving quality, but it's not necessarily labor saving. So I saw the robots being used to move around goods and provide those kinds of services. Do you see a point coming where robots actually replace or act as a substitute for clinicians or professionals in a hospital? And what might that look like in the future?
I think that robots will augment professionals. I think they'll shift things around. Just like the case with AGVs is we're replacing porters, right? So we're not paying someone to push the cart up and down, but we still need, it changes the purpose. It will still need people on either end to run the system. We need to have people manage the system to run it. So it may not replace all the staff, but it augments it and it shifts the skill sets around as well. But in that particular case, in the one with Iowa where we reduced it to 150 beds, that is a complete staff augmentation. That means we don't have staff, whether like or not, so we have to put the robots in. Otherwise, we're not going to be opening beds up. So that's replacing staff altogether. Not to save money, but that's just our necessity. Depending on the union wages and such are in place, that also determines the return on investment, but that would replace it. I think even robot surgery is not replacing surgeons. I don't think it's going to do that. I think robot surgery is something that, the surgeon's skill sets has kind of changed. They have to operate this robot. And so I don't think that's the case. But there's some automations, for example, with just general building operations. automation can reduce the facilities management of the facility from itself, reduce the costs. If you have smart buildings, you're measuring with sensors in the buildings themselves. We can show that there's a reduction in cost of running the building. But really, the majority cost of things is the labor costs. And I think, I think that the only case that we've seen is the ports, the low value tasks that can be replaced.
Okay, great. Thank you so much. Big round of applause.
Thank you.